Hello, welcome to Sonography Radiology Training Channel. This series of videos is about placental imaging. This is the 7th video in this video series with title of Placental Hematomas. The outline of this presentation include introduction, prevalence and risks of placental hematomas, signs and symptoms, diagnosis, classification of placental hematomas including subchorionic hematomas, retroplacental hematomas, and subamniotic or preplacental hematomas, prognostic factors, and final teaching points. At first, introduction. Intrauterine hematoma is a common phenomenon on routine obstetric ultrasonography, especially in the first trimester of gestation. The placental hematomas are often identified in the setting of vaginal bleeding, particularly in the first trimester. When describing a hematoma, it's suggested that use of the term hemorrhage should be avoided. Placental hematomas can occur on the fetal side, including preplacental or subamniotic hematoma or subchorionic hematoma, or in maternal side, famous as retroplacental hematomas, or be centered within the placenta. At ultrasound, placental hematomas appear as well-circumscribed masses with echogenicity that varies according to chronicity. They are hypoechoic or unechoic in the acute phase, heterogeneously echogenic in the subacute phase, and unechoic in the chronic phase. Doppler study should reveal absence of internal blood flow. This finding allows differentiation of hematomas from other placental masses like chorioangioma. The role of MR imaging in the diagnosis of placental hematoma is not well defined, but placental hematoma can be expected to follow the signal intensity progression seen with hemorrhage elsewhere in the body. This axial T2 fast spin echo-MR image shows a low signal intensity mass along the margin of the placenta, but this axial T1MR image shows predominantly intermediate signal intensity mass with internal areas of increased signal intensity. The signal intensity characteristics and the location of the mass are consistent with a subchorionic hematoma with hemorrhage of varying age. Prevalence and risks of placental hematomas. The prevalence of subchorionic hematoma is approximately 2 to 3% in the first or second trimester. First trimester hematoma has been associated with increased risk for adverse pregnancy outcome regardless of whether the sonographic findings are accompanied by vaginal bleeding and regardless of hematoma size. This ultrasound image from an 8-week fetus associated with a large subchorionic hematoma which occupies at least 2/3 of the chorionic size circumference. Another risks of placental hematoma including preterm birth rate about 50%, placental abruption rate a 3-fold increase, and fetal death and stillbirth a 2-fold increase, such that approximately 1% of women with hematoma experienced a stillbirth. No specific surveillance protocol has been demonstrated to have clinical utility in reducing rates of adverse outcome in this setting. Importantly, pregnancy outcomes are good in most of those in whom subchorionic hematoma is an incidental sonographic finding. Signs and symptoms. Most patients with a small subchorionic hematoma are asymptomatic. Symptoms include vaginal bleeding, abdominal pain, premature labor, and threatened miscarriage. Diagnosis. Of course, ultrasonography is the preferred method of diagnosis. The hematoma is considered small if it's under 20% of the size of the sac and large if it's over 50% of the sac circumference. An acute hematoma has an echogenicity similar to that of the placenta, making sonographic visualization difficult. This transabdominal view of the uterus in the second trimester showed acute subchorionic hematoma. As we can see in this image, the hematoma shows the same echogenicity like placenta. However, the hematoma generally becomes hypoechoic relative to the placenta within 1 week, and by 2 weeks the placental hematoma appears sonolucent. This transabdominal mid-sagittal view of the same patient in the pregnancy demonstrates the subchorionic hematoma more hypoechoic and located overlying the cervix. An indirect sign of the presence of a hematoma is apparent thickening of the placenta, which is associated with worse outcomes. This image of a 37-week pregnant woman with placental abruption illustrating an amorphous placental image with a mixture of hypoechoic, hyperechoic, and echo-free areas. The placenta is abnormally thickened, about 8.7 cm in thickness. Classification. Hematomas are classified by their location between tissue layers. Subchorionic hematomas, the most common type of the hematoma, are between the chorion and the endometrium. Retroplacental hematomas are entirely behind the placenta and not touching the gestational sac. Subamniotic or preplacental hematomas are contained within the amnion and chorion, which is a rare form of the hematomas. Subchorionic hematomas. Subchorionic hematoma between the chorion and endometrium and or at the margin of the placenta is the most common type, about 81%. This image shows a resolving subchorionic hematoma detected at 13 weeks gestation, extending below the margin of the placenta. Although a subchorionic hematoma can occur anytime during pregnancy, it's more common in the first half of the pregnancy, and its appearance will change as the hematoma organizes, from hyperechoic to hypoechoic and finally sonolucent. A subchorionic hematoma appears on ultrasound as an irregular hypoechoic space, sometimes crescent-shaped, around part of the gestational sac. The hematoma usually has internal echoes and is separated from the fluid inside the gestational sac by a thick band of tissue. It must be differentiated from separation of amnion from the chorion, a normal finding in the first trimester in which the very thin, smooth amnion lies between the inner amniotic fluid and the outer chorionic fluid. You can find full explanation about spontaneous chorioamniotic separation in this video, which I will put its link in the description section. There is general consensus that a small subchorionic hematoma carries little or no risk. Most studies, although not all, have found that a large subchorionic hematoma carries an elevated risk of subsequent pregnancy loss. Massive subchorionic hematoma or thrombohematoma, which so-called Bruis mole, is a large maternal blood clot with a thickness of at least 1 cm that separates the chorion plate from the villus chorion. A Bruis mole is an unfortunate misnomer because this entity bears no relationship to the molar pregnancy. Especially when presenting preplacentally, massive subchorionic hematoma is commonly termed Bruis mole and has been linked with poor pregnancy outcomes such as fetal growth restriction and intrauterine fetal death. The estimated incidence of this condition is low, about 1 per 3,000 pregnancies. We must know a few practical points about massive subchorionic hematoma. First, physicians should consider intraperitoneal massive subchorionic hematoma as a differential diagnosis when placentomegaly with FGR is observed. Ultrasonic findings of massive subchorionic hematoma are highly varied, and the condition is not always easy to distinguish from placental parenchyma. This ultrasound image in a fetus with obvious FGR shows a spherically enlarged placenta without any internal vascularity. This ultrasound image shows intraplacental fluid level at 24 weeks gestation, and color Doppler sonography showed no blood flow in the reticulate sonolucent areas. This is another case of massive subchorionic hematoma. A 17-year-old woman at 22 weeks of gestation following the observation of FGR, oligohydramnios, and placental enlargement. This ultrasound examination revealed a large placental mass with mixed high and low echogenicity measuring approximately 7.5 cm in thickness. The range of presumed hematoma is indicated by the dotted lines. This gross image of the placenta after delivery shows a subchorionic blood clot measuring about 12 cm covered a large portion of the placenta and had well-defined margin on the fetal surface. Another example of massive subchorionic hematoma, a 33-year-old woman at 24 weeks gestation. Ultrasound screening scan performed showed FGR with large placental mass about 14 cm. This image shows a heterogeneous aspect of the placenta, and the calipers indicate the limits of the massive subchorionic hematoma. This image shows the placenta is heterogeneous on the chorionic side and more echogenic on the basal side. Another practical point, MRI for massive subchorionic hematoma is useful to confirm diagnosis and follow-up when used in combination with ultrasonography. This T2 MRI image at 24 weeks gestation shows that the placenta is heterogeneous and enlarged. This arrow indicates fluid level in the image, which correlate with fluid level as we can see in ultrasonographic finding. Retroplacental hematomas. Retroplacental hematomas occur between the placenta and the myometrium. Its incidence about 16% of all placental hematomas. Retroplacental hematomas are entirely behind the placenta and not touching the gestational sac. Retroplacental hemorrhage occurs when there is perigestational hemorrhage that is confined to the retroplacental space. The source of bleeding is probably from spiral arteries. What is the etiology of retroplacental hematomas? In late pregnancy, it's typically caused by a placental abruption. Sonographically, a retroplacental hematoma may mimic a thickened placenta because a hematoma is commonly isoechoic to the placenta. In this ultrasound image, we can see a large retroplacental hematoma detected at 25 weeks gestation, detaching more than 50% of the placenta, and we can see here retroplacental venous complex separated the hematoma from the placental tissue. Retroplacental hematoma should be suspected if the retroplacental hypoechoic zone is thickened more than 2 cm. Otherwise, the retroplacental hematoma may be hypoechoic or may be of heterogeneous echogenicity. This image from the same patient 1 week later shows a resolving hematoma contained posterior to the placenta. Color Doppler study will reveal the absence of the internal blood flow. This finding allows differentiation of hematoma from other placental masses. What is the differential diagnosis of retroplacental hematomas? Focal retroplacental myometrial contraction, which is a transient finding, causes of placentomegaly, particularly in isoechoic hematoma, and retroplacental uterine leiomyoma, considered in hypoechoic hematoma. Subamniotic or preplacental hematomas. Preplacental hematomas occur between the placenta and amniotic fluid or placental membranes, namely called subamniotic hematoma. Its incidence about 4% of all placental hematomas. The source of bleeding is possibly from the fetal vessels and may be associated with maternal hypertension. They have less clinical significance. However, the patient may present with vaginal bleeding or uterine contraction, resulting in abortion, intrauterine growth restriction, preterm labor, placental abruption, and fetal distress. This ultrasound image shows a preplacental hematoma detected at 18 weeks of gestation, located between the placenta and the fetus. And here is a preplacental or subamniotic hematoma. This is another example of preplacental or subamniotic hematoma, which color Doppler study shows no any internal vascularity. Prognostic factors. Multiple factors, including the volume and location of intrauterine hematoma, diagnosed gestational age, duration, and simultaneous presence or absence of vaginal bleeding, may play important roles in the prognosis for pregnancy outcomes. Several studies have been done on prognostic factors, but this article, which was published in 2014, is the most complete article in this field, which covering the period from 1981 to 2014 and focused on the pregnancy outcomes associated with different symptoms of an intrauterine hematoma. According to this article, we will review the prognostic factors. At first, the volume of intrauterine hematoma. Overall, the association with the volume of the hematoma and pregnancy outcome still remains controversial. However, the size of a hematoma may be a poor reflection of the accurate amount of hemorrhage because it depends upon the following factors: the ability of blood to escape through cervix, the rate of intrauterine bleeding, and the time between the acute hemorrhage and the ultrasound scan. So, the influence of external bleeding on the pregnancy outcome in the pregnancies with intrauterine hematoma also needs further in-depth discussion. Position or location of a hematoma. Subchorionic hematomas often detach only the placental margin, while retroplacental hematoma represent large placental detachment. Therefore, the placental impairment seems to be more serious in retroplacental hematoma than in the subchorionic hematomas. However, as an exception to subchorionic hematoma, chorionic peripheral separation would result in release of hemoglobin with its degradation products into the amniotic cavity and eventually lead to diffuse chorioamniotic hemosiderosis, clinically known as chorionic abruption. Pregnancy complicated by diffuse chorioamniotic hemosiderosis is supposed to be closely associated with preterm delivery and newborn respiratory distress. In a word, the position or location of a hematoma relative to the placenta or the uterine wall was important on the prognosis for pregnancy complications. Gestational age at diagnosis. Only the large hematoma occurring after 16 weeks gestation had a deleterious effect on the outcomes. In general, the earlier gestational age a hematoma was diagnosed, the worse outcome the pregnancies tends to have. In short, the prognostic value of gestational age at diagnosis means before 12 weeks of gestation or after 16 weeks of gestation still remains controversial. Duration of a hematoma. In short, the majority of the published literatures suggests that a persistent hematoma from first trimester to second and third trimesters would make a great contribution to adverse pregnancy outcomes. Influence of the presence of vaginal bleeding on pregnancy outcome. Neither subchorionic fluid or subchorionic bleeding would increase the risk of embryonic death unless they were accompanied by clinical bleeding at the same time. In brief, the presence of vaginal bleeding will aggravate the state of complication in the pregnancies with a hematoma. Moreover, the longer the bleeding lasts, the worse the prognosis is. Therefore, this impression that the hematoma and bleeding are related to an underlying placental problem that essentially causes adverse outcomes and should not be considered independently would have been a more accurate statement. Now, please pay attention to these final teaching points. First trimester hematoma has been associated with increased risk for adverse pregnancy outcome regardless of whether the sonographic findings are accompanied by vaginal bleeding and regardless of hematoma size. Importantly, pregnancy outcomes are good in most of those in whom subchorionic hematoma is an incidental sonographic finding. An indirect sign of the presence of a hematoma is apparent thickening of the placenta, which is associated with worse outcomes. The hematoma and bleeding are related to an underlying placental problem that essentially causes adverse outcomes and should not be considered independently. Placentamegaly, particularly when accompanied by FGR, should be included as one of the differential diagnoses for intraplacental massive subchorionic hematoma. Intrauterine growth restriction and compromised fetal circulation demonstrated on Doppler studies should be consequences of uteroplacental insufficiency from the massive subchorionic hematoma. Furthermore, this case highlights the potential use of MRI for diagnosis of massive subchorionic hematoma when ultrasound diagnosis is difficult. Now, I suggest two others of my videos that are close to this video in terms of matter. And thank you for your attention.